Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gollin.
Hey everyone, welcome to the Gastro Girl podcast. We're so excited today to have Dr. Milli Gupta back. She's a gastroenterologist in Canada, and she was our guest on one of our most popular podcasts ever. She did Eosinophilic Esophagitis 101 a couple years ago. And since then, there's been some new treatments approved. So we're going to give you a whole new revised edition of Eosinophilic Esophagitis 101 with Dr. Milli Gupta. Welcome. We're so happy to have you back.
Thank you so much for having me back. It was fun doing it the first time, and I'm excited for this time as well.
Yes, thank you. It was amazing to see all the feedback and all the questions we've gotten from your episode. So with all the new advances, we thought we'd update in this episode. So let's just start with the basics. What is EOE?
Sure. So eosinophilic esophagitis is an allergic condition that involves the esophagus. And we think it is related with an allergic reaction that occurs in the esophagus, but it is not like the typical allergies one may think of when, for example, you go outside and you get a runny nose from hay fever or pollen allergies. The type of inflammation we believe is occurring in the esophagus takes a little longer to occur, but we think it's triggered by an allergic response to food. And in some instances, it can also be aggravated by environmental allergens like pollen. So it is predominantly involving the esophagus. And so it tends to mostly occur in all ages and all ethnicities as well as genders. The way it presents, though, is variable. And I don't know if you want me to jump into it or if you'd like to ask anything.
Yeah, so I'm going to ask you about the symptom. Yeah. So I know their symptoms are different in children and adults. So can you break it down? What are the symptoms in children and then what are the symptoms in adults?
Yeah, sure. So children may present more with picky eating, nausea, grabbing up their abdomen, not necessarily their chest, but they're just feeling upset or have a tummy ache when they're eating. There can be weight loss. There can be nutritional issues. The child may be called a picky eater, but really they're just not able to tolerate or digest certain foods. Whereas, adolescents and adults may present more so with difficulty swallowing certain foods. They may describe reflux, chest pain, indigestion, heartburn. They may also describe a sensation of food sticking, slowing down. And so there are a few symptoms that if you were to consider your own eating behaviors, it may help you figure out if perhaps you need to be seen by a doctor. And so the acronym is IMPACT. So IMPACT. So IMPACT is a good way to for physicians to ask their patients, but also for patients to kind of review, am I trouble having swallowing, and in what ways am I accommodating for it? Because patients are excellent at accommodating when something is bothersome, and it's just human nature to do so. So I stands for imbibing fluids, so using fluids to pass the food down. M is modifying the nature of food you're eating, so perhaps avoiding certain textures like hard breads, pills. P stands for prolonging the time you're eating, so taking way longer than perhaps you used to take before, or being the last one at the table. A, again, references the avoidance of certain food groups or textures. Again, if it's breads or hard meats, steaks. C means chewing excessively. So each bite is taking longer and longer to chew just because you really want to make sure that nothing gets stuck, especially if you're in social gatherings. And T is turning away pills or even tablets because you're just concerned that it's going to get stuck and you're going to have troubles. Children may not necessarily present with this, but adults and adolescents will most likely have some symptoms. But, it's harder for adolescents to really appreciate that because it does take years for patients to develop these kind of behaviors of modifying what they're eating, how they're eating. So I would say it's more often in the adults that when we ask patients to reflect back, they realize, I've been doing this for like decades and I didn't realize that might have been why.
Yeah. And, talk a little bit about food impactions, because this is a big one. I had a friend who every time she ate a chicken kebab, she would end up, having a food impaction. And she was talked about going to the emergency room several times. And it wasn't until years and years later that she finally went and was diagnosed with EOE. So talk a little bit about that.
Yeah, no, absolutely. Food impactions are very scary when they happen. In some instances, they are a medical emergency. And the instance I can think of first is if you are finding yourself unable to breathe. Absolutely. Somebody might be around to give you the Heimlich maneuver. But if you're still anxious, you're not able to breathe, definitely go to the local emergency department. There's also when patients have difficulty swallowing saliva, which is our spit. And if that's not able to go down, it means that there's a blockage in the esophagus that needs to be removed. And usually that requires an emergency visit to the hospital so that a gastroenterologist or a surgeon can remove that piece from the esophagus. It does tend to occur quite often in patients, and it may also be the first time a person presents with that, and that's when they get diagnosed. I think physicians and patients alike are much more aware of this disorder, so they are beginning to be more conscious of looking for it. If somebody suggests that they have had trouble swallowing or they had an episode where food got stuck, but they kind of brushed it off, I think a lot of us are now beginning to be more aware and go, you know what, that's not normal. Maybe we need to look into it further.
So it's not normal for food to get stuck in our throats at all. It's not normal.
Well, there are obviously instances where if you're distracted and, you take a bigger bite and you kind of get choking episodes that way. But I just want to, highlight that it may be that a person tells themselves that they've had a couple of those episodes and they keep saying that's the reason. I just want them to kind of reflect and perhaps say, maybe there's something more. So one-off might be reasonable to say, don't worry. But I think more than that, especially if the person has allergies or if they have a family history of swallowing troubles, certainly it's worth investigating.
So, you started to mention diagnosis. So how is EOE diagnosed?
Yeah, so there's two parts that are required to make the diagnosis. The first is that there has to actually the patient has to have symptoms. They have to have troubles with swallowing, or the medical term is esophageal dysfunction. So there needs to be a disorder that the patient is struggling with symptom-wise. They're having trouble swallowing, they're picky eating, reflux. I mentioned those symptoms already. The second is that we need a camera test, a endoscopy, to actually acquire samples of from the esophagus itself. And so those are small tissue samples called biopsies. And then those have to be sent to the pathologist, who will then look at them under a microscope and confirm if there is any inflammation in those tissue samples or not.
So we always hear the word eosinophils. Can you just give us a brief overview of what they are and why they're so important in this disease?
Yeah, sure. So eosinophils are a type of white cell, and white cells are generally in our body to help defend against infections. And normally the esophagus does not have any eosinophils. And so their presence in the esophagus is a concern. And it leads us to wonder, well, why is it there? And over time, it's taken, researchers a long time to come to appreciate that. We initially thought it was only allergies that would trigger this kind of presence in the esophagus. But as I was trying to mention earlier, there is an allergic reaction in the esophagus, but it's also triggering other inflammation in the esophagus. So the reason we believe that having these cells are abnormal in the esophagus is because they're reflecting an allergic reaction, but they're also highlighting that there is something going on in the esophagus that needs closer look. And the reason I say that is because some patients with really bad reflux disease can also have eosinophils in their esophagus. But it's the doctor, specifically the gastroenterologist and pathologist, as well as the patient and what their symptoms are, that have to all come together to realize if the patient may actually have eosinophilic esophagitis or some other disorder.
So this is really interesting because, we've read in papers that it can take sometimes up to 10 years for a diagnosis of EOE. And I want to highlight this, or I want you to highlight this, because what happens to the esophagus if there is EOE present and it's not diagnosed or treated? Can you explain why it's so important to get an accurate diagnosis earlier rather than later?
So the challenges with eosinophilic esophagitis is that it's got a variable course of disease, but what we understand is that the longer it goes undetected, the longer the inflammation stays in the esophagus. And that chronic inflammation in the esophagus has a risk of causing scarring and changing the nature of the function of the esophagus. So normally the esophagus is a very flexible tube. It should be able to do this when food is entering into it. Over time, if there's inflammation, that flexibility in the esophagus starts to drop, and it becomes harder and harder for it to push the food down. So it can get stiffer. And that stiffness is why some people have the sensation of food sticking or catching. And as the reason I say the presentation of this condition is variable is because some people may never go on to develop stiffness in their esophagus, but many people might. And we are still not clear on which patient population is at higher risk of having fibrosis or scarring and stiffness in their esophagus and which ones aren't. And it's because of that inability to differentiate which patients are going to have a harder time down the road or not that we suggest being investigated for symptoms and also looking at treatments.
No, thank you for that. And, that leads me to my next question about risk factors. Are there family history ties? Are there any other demographics that are more prone to EOE, or is there an age that it's usually diagnosed at?
It's a great question because I think there's two factors to it. One is we recognize it to be it's possible for anyone and everyone at any age to have this condition. It's also appreciated that all genders and ethnicities are at risk. However, when you look at the publications, there is a bit of a bias because a lot of the publications so far have been from Western countries, European countries. And also, as you mentioned, there's about a 5 to 10 year delay in time of starting the inflammation in the esophagus to when the patient eventually has the diagnosis given. And so it may appear that patients are usually in their 20s to 40s when they're getting diagnosed, but it's likely that they've had the disorder for earlier, and it's just that we're catching them at that point. Also, there's a lot of people we're not detecting. And the reason is because a lot of people have learned how to live with this condition. Or, as I said to you, if the symptoms are picky eating, vague abdominal pain, reflux, it's going to be hard to, for a patient to kind of go, okay, this I have to take very seriously and go in because they might have already convinced themselves that that's just what it is. This is just who I am. This is how things are. So there's multiple layers of that confound the ability to give you an exact answer.
Now, there's also studies that show a link possibly between asthma and allergies with EOE. Can you explain that and what patients should know at this stage about that?
Yes, absolutely. Thank you for that. So more than 70% of patients with eosinophilic esophagitis will have at least one, if not more, allergic or atopic conditions. So these can include things like food allergies that have been detected by an allergist and confirmed, asthma, allergic rhinitis, eczema, chronic nasal polyposis syndromes. And so the domain of allergists, dermatologists, ear, nose, throat doctors, respirologists, there's this now appreciation of overlap with eosinophilic esophagitis. And so if you have a family history of that or you have these conditions yourself, be it during childhood or in adulthood, and then you start to develop symptoms of difficulty swallowing, it's definitely reasonable to consider eosinophilic esophagitis as a possible condition that could be contributing. So absolutely, you're right there. There are some family history patients. So there might be a tendency that perhaps your dad or granddad or grandma had trouble swallowing and they always took their time at the table chewing. 40, 50 years ago, we weren't looking for this disorder as we are now. So we're not sure if that's what they had. So there is still a lot of learning that's coming that way, and also understanding that perhaps we need to take those kind of history seriously as well. So those are the two ones. There are some genetic markers that we appreciate as being present, but we don't have those tests commercially available. So it's really hard to recommend them. And if you want me to go a bit scientific, I don't want to get too heavy on it, but we do think there is a priming of the body from these allergic conditions. And then eosinophilic esophagitis is just one of those other disorders that eventually over time a person is at risk of acquiring. We just don't know what it is that triggers them into getting the eosinophilic esophagitis. So there's this concept of a allergic march. And as the patient is perhaps acquiring allergies, then EOE is at the end of that allergic march, so to speak. And so that's the reason we see this connection with allergic or atopic disorders, because there seems to be a connection in how patients develop asthma or eczema. There seems to be a connection in how the same kind of phenomenon and inflammatory changes are occurring in the esophagus. So the changes occurring in the skin or in the lungs or, in the nasal passages are occurring also in the esophagus as to, what's triggering them. Food is definitely a trigger, but is it something in the environment as well? There's a lot of, interest and research in this. So hopefully in the next few years, we'll have better answers.
Yeah, and I think our listeners are pretty interested in the science and explanation and also the connections. We've also seen the relationship between inflammation, right, and EOE, which is another area. I don't know if it's too sciencey to get into that, but could you just mention a little bit of, the role of inflammation in EOE?
Allergic reactions are a type of inflammation, and we think that what eosinophilic esophagitis and atopic allergic disorders are experiencing is a type 2 inflammatory process. And so it is not just eosinophils that are getting involved in that type of inflammation. It's mast cells, basophils, there's multiple inflammatory cytokines, interleukins. It's a huge party, if you want to call it, of inflammation. And because of the density or the amount of inflammation that's occurring, the response of the body is to have scar tissue lay down or fibrosis. And it's because of that, over time, patients can go on to get scarring and stiffness and narrowing of their esophagus. From what the researchers have found, there is these allergic disorders do seem to switch something in the genetics that then once the genes have been turned on or off, that continues to rev the inflammation on. But what we don't know is why some people have a very mild form of eosinophilic esophagitis and why some people are more prone to the more aggressive form where they get narrowing and scarring and difficult food impactions as their way of manifesting the disease, versus some people will just have that sticking sensation and otherwise just drinking fluids will take care of it.
Yeah, no, I appreciate the insight, because we've also seen advances since the last time we spoke about treatment options, which is exciting for patients because we don't want to present information like it's all doom and gloom. We also like to give hope and information to make decisions. And the reason why I mentioned inflammation is because we've seen treatment options that have come out that address that inflammation. So it's important for patients to at least understand at a base level so they can have these intelligent conversations with their healthcare providers. So thank you for that information. And now I'd really like to get into the treatment options. And since we last spoke, there's been some really exciting advances in this area. So let's break it down. There's children and adults. So for children, what are some of the treatment options and what other advances that we've seen since 2 years ago?
Yeah, so for children, there is a injectable biologic medication called dupilumab. And as of January 2024, it is now approved for children over the age of 1 to 11. And children over the age of 11 have already had approval for this medication, and adults already have the approval for dupilumab. So that is the name of the injectable biologic, dupilumab. And then the second agent that has recently been approved is an oral medication, and it is for children over the ages of 11 and adults. It is not approved in children below the age of 11 at this time. And it is called Eohilia. And again, it's an oral medication.
Great. And then for adults, I think what are the options for adults?
Yeah. So for adults, Eohilia is an approved oral medication, and dupilumab is an approved injectable biologic medication. And this is for the US. Obviously, it is different in Europe and Canada because they have their own regulatory bodies, and the approvals there have occurred differently for different reasons.
The other, treatment option that we hear, and you mentioned it in your last episode as well, and we've had dietitians, is the elimination diet. Can you explain what that entails for a patient who undergoes that?
Yeah, thank you for asking. Since the last podcast, there's actually been a bunch of publications that have looked at different alternatives for diet. So, to review, there are various types of diets you could try in eosinophilic esophagitis. The one that is most popular and that is most recommended is called an elimination diet. And that is the one we recommend having dietitian support for, because what you have to do in that is actually remove certain food groups, and then have another checkup with your gastroenterologist to confirm if that was helpful in getting rid of the inflammation in your esophagus. So it involves a lot of scopes. It also involves removing the food group completely, which means that it is a burdensome option for many patients, especially when they're young patients who have a lot of social aspect of their lives still developing. And so the new research or the new changes that have occurred is that back, I think, when we spoke, there was 6 food groups that were eliminated, and some in research was showing that you could actually even just do 4 food groups at a time. But now there's actually been a study published that looked at one food elimination, and that was milk, cow's milk. And it was done across 10 US centers, and it was mostly in adults. And it looked to be just as effective as 6 food elimination attempts by patients. And so if somebody was looking at a diet option and they thought, I could try it, but only if it's perhaps one food group, then the recommendation now is to try cow's milk elimination, and then to have an assessment or a checkup with the scope in 6 to 12 weeks, depending on what your gastroenterologist can accommodate.
And the importance of the scope is you have to see what the esophagus looks like and the number of eosinophils on biopsy to see if there was an effect, correct?
Absolutely. And the reason that is because unfortunately, we know that symptoms do not correlate with how the inflammation in the esophagus looks. So patients will tell us, I feel great. This medication has made a massive difference. I can go eat and, I can finally socialize and I not worry about things. But if a camera test is completed and there's inflammation, depending on the severity of the inflammation and the degree of inflammation, there might have to be a conversation about, is this treatment effective, or is it partially effective? Like, is it working perhaps 50%? Could we aim for better, or is it not working at all? And the literature has shown this discordance, as we call it, or this lack of relationship between symptoms and inflammation. And so we're actively looking at different ways of checking how patients feel with how the inflammation is, because we understand patients don't like to be coming back repeatedly for scopes, taking time off to get sedated and having family drive them.
Now, can a patient be on, say, an elimination diet and a medication, or, do they need both, or is it one or the other?
It's recommended at this time, one or the other. Obviously some patients may require multiple treatments, but it's usually in consultation with the eosinophilic esophagitis expert or reviewing their case in detail. It's not, the first line is to try one treatment at a time.
Yeah, that makes sense because you don't know what's having the effect and making you feel.
Absolutely.
So when a patient's on a medication, would they get scoped as much, or is it once a year, or every 6 months? How does that work?
Yeah, so the reason the timeline of 6 weeks is for diet is because that's how it was studied. But for a lot of the other medications that we've described, it's anywhere from 8 to 12 weeks. So there is a bit of a range and flexibility. And that's based, again, on the research trials that were published. Dupilumab was a bit different in that their studies published up to 6 months of time period between starting treatment and checking. And so there's variability depending on the type of treatment you take.
Well, this has been such great information. But before we go, we always like to give our listeners resources for support. And you're really big on this, as you were in the last episode. What are some of the support groups that you recommend, or advocacy groups for patients who are just diagnosed, or for parents of children who want to learn more, or they're living with EOE? Like, what do you recommend for patients?
So there's one that comes to mind immediately is the I think it's still called, and I'm just double checking. Yeah. So the American Partnership for Eosinophilic Disorders, they often tend to have a lot of good talks, not only on eosinophilic esophagitis, but also some of the other orphan rare disorders that are eosinophilia of the gastrointestinal tract. In Canada, there is one called Food Allergy Canada, and they do a lot of publications and brochures for patients. They also have talks like yours. Obviously, Gastro Girl is wonderful. And, when it comes to patient advocacy, I've been told repeatedly, like social media is a great avenue for patients to come together. So I know there's a lot of Facebook groups, and I don't have any specific names that I can recommend. But, in my local city, I know that there have been groups that have come together just to be able to review the disorder, supports on how to make a diet work, and places that people can go to eat, and foods that are recommended in EOE type diets, just because of the nature of the textures and consistencies that people like to have.
Yeah, the first one you mentioned, AppFed, that's a great organization, and they have through all the stages of the journey of a patient. And if you're a caretaker, a caregiver of a child, or even someone in your family that's living with EOE, it's a great resource. And they have other, I think, links to other resources. So I think it's appfed.org. But Dr. Gupta, this has been so enlightening. I appreciate your time. This is such a wonderful overview, and I hope I'm sure our listeners will get some good information from this, and they can take to their healthcare providers to hopefully start the conversation and get on the road to proper diagnosis and treatment. So thank you so much, and have a lovely day.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.